going, this is the last lap around the track, right? So, hour and a half, less than. We're going to cover hypertension and diabetes. You're going to fill in a few blanks in terms of drugs and clinical assessment, but otherwise, what we're going to do is apply, the basic protocol to these, and I'm going to show you why it's relevant. So, I could say, wow, I've got this great protocol and it cures everything that walks into your office, but to a large extent, there's some truth there, and so what I want to show you now is how to actually apply it clinically and why it matters, and what the results are. So, let's do that, assuming that this remote control gets me going, and so far it's not working at all. So, what am I going to do about that? Step over here, I suppose. Oh, yeah. There you go. Ta-da. Yep. Thanks. Oh, you're good. So let's apply this protocol now to first round of clinical conditions: diabetes, insulin resistance, hypertension, obesity, things like this. So obviously this is a topic I have some interest in because I just published a book last year, 2 books on hypertension. Hypertension is the most common diagnosis in the practice of general medicine or family medicine. So for those of you who are interested in taking on a more primary care approach in your practice, this is certainly something that you want to be interested in. Hypertension and diabetes are tightly clustered. When we combine those two together and we add in a few other criteria, we get pretty quickly to a diagnosis of what we call metabolic syndrome. Most common diagnosis, as I already said, I've got a review article on the differential diagnosis of hypertension on my website. You can download that for free. It was published December of 2010 in the original Internist. And as far as I know, it's the most comprehensive review of the differential diagnosis of hypertension that's ever been published. So it's also excerpted from my book, so it's in the books as well, the 2 books I published last year. So let's talk about some of this material. I covered it once in Chiropractic and Naturopathic Mastery of Common Clinical Disorders. Then that was published as Chiropractic Management of Chronic Hypertension, which I've obviously advocated. That very quick blurb was a review article just suggesting that the chiropractic profession might take on hypertension. Integrative Medicine and Functional Medicine for Chronic Hypertension was published last year, and then I updated that into the Integrative Chiropractic Management of Chronic Hypertension, also published last year. So let's talk about chronic inflammation, cardiovascular disease, metabolic syndrome. We looked at this slide last time. Again, we're trying to appreciate the interconnected nature of different body systems and how this reflects the clinical reality that we have to deal with. So if we look at this model, and then we apply it to this model, which is more specific for hypertension and metabolic syndrome, you'll notice that it's going to be pretty impossible to make one drug that addresses every component of this web, right? So as I mentioned before, one day I was teaching pharmacology, and I was going through the drugs that are used for the treatment of diabetes, and I realized I was just looking at my own slides, and I looked at those drugs, and I thought, wow, none of these drugs ever has an opportunity to really cure these patients. So we're not really treating them. We're just drugging them into improved parameters, but we can't even say it's improved performance, right? Because if you look at the sulfonylurea drugs, they improve numbers, they lower blood sugar levels, but they also increase mortality. So let's see what we can do about these things. One of the things I think is really interesting is the correlation between nutrient deficiencies and impaired satiation or insatiability, so to speak. So when people have nutrient deficiencies, they develop carbohydrate cravings, etc. So part of the way that we get patients to be of normal weight if they are overweight is we supplement them with multivitamin and multiminerals. So we're trying to enhance nutrient density because nutrient density has a satiating effect. High carbohydrate foods do not promote satiation, even though people might enjoy them in the short term. We looked at this before. We talked about how, for some odd reason, medical doctors don't get any training in nutrition. Doesn't really make sense, but it's certainly the reality, and it's a well-documented reality, so it's not just like some conspiracy theory. Plenty of articles have documented that this is like a pervasive problem in medical education. So then the question becomes, well, why would that be? And you probably can come up with your own answers. Who established the rightness of medical management of chronic hypertension? Mostly the drug companies who are selling drugs and the medical profession which sells prescriptions, right? But just because they're both in agreement doesn't mean that they're right. So drug companies, of course, make medications. They sell those to patients who are authorized by medical doctors to get those prescriptions. So there is kind of a vicious cycle of self-perpetuating paradigms there. And this is what I call the drug box. And so our goal is to think outside of the drug box, because a lot of times the best answers are not within the drug box of prescription items, you know? And I think we see that very clearly with hypertension and diabetes. The best treatments for hypertension and diabetes are not drugs. That's very clear. If we're defining good treatment as safe, effective, and cost-effective, then drugs should be the last resort. Except, again, as we can always make an exception, the exception is acute management of, acute hypertension. Patient comes in with blood pressure of 240 over 120. They're not eating a salad. They're getting hydralazine intravenously, right? So, but we need to not have our patients have a McDonald's on the first floor. Thank you very much. We can still do evidence-based medicine even though we're not using medications. We've already gone through these 7 components. See, remember I told you there was going to be some redundancy? So you're already seeing a little bit of that, but there's a purpose behind it. Not simply to fill time. We're actually trying to reinforce some of the material. So we talked about how we can remember all of this, and the way that we do that is through the acronym that I gave you before, FIND-SEX. Now you know the components, now you know how to apply it, and it's fun and gratifying. So we're going to talk about how to do this in a way that is specific for hypertension, metabolic syndrome, and diabetes. So I'm going to zip through some of those. So let's talk about, I'm going to go back just for the sake of my own completeness. Let's talk about the definitions and some of the conditions we're talking about. Hypertension starts officially at 140 over 90, even though increased mortality starts at 115 over 75. Diabetes mellitus type 2, best diagnostic test that I'm aware of right now is hemoglobin A1C. I haven't looked at this in a couple of years, but the criteria at that time was 6.5%, warranted a diagnosis of diabetes. Metabolic syndrome is hypertension, diabetes, with some other criteria. Usually abdominal obesity, visceral adiposity, some type of inflammatory state measured by high-sensitivity C-reactive protein, some type of hypercoagulability, usually measured by elevated fibrinogen levels. And that gives us a diagnosis of metabolic syndrome. Obesity is a body mass index greater than 30. And I think components of this protocol, as I mentioned before, also apply to osteoarthritis, chronic pain, especially fibromyalgia, Parkinson's, and Alzheimer's. As I mentioned just a moment ago, micronutrient deficiency increases the risk for overweight and obesity. This was published in 2007, showing that patients who had nutrient deficiencies had higher risk for developing obesity. And we all know that that's already been substantiated. So if you remember back to your days of reading Robbins' Pathologic Basis of Disease, and maybe even in your first nutrition course, you probably remember learning about a condition called pica, right? P-I-C-A? Everybody remember that? So what is pica? It's a desire to consume non-nutritive substances in the face of iron deficiency anemia, right? So pica, classically associated with iron deficiency, and people develop cravings for non-nutritive substances like dirt, right? Well, what goes on in patients who have this insatiable appetite, which ultimately leads to obesity and overweight, is they have what I call junk food pica as a result of being nutrient deficient. And so what would be the expected physiologic response, assuming that the body wants to protect its own existence? If the body were nutrient deficient, what would you expect the response to be? It would be to reduce metabolic rate and to increase consumption of anything it can get, right? Because it's looking for nutrients and at the same time it's trying to conserve energy. So we get a hypometabolic state confronted with increased consumption of whatever's available. Now, in the natural world, what would be available? Fruits, vegetables, nuts, seeds, berries, and lean sources of protein, right? In our world, what's available? Potato chips, 500-calorie latte, pizza, a lot of foods that are high in calories and fat and very low in nutrients, right? So it's a very nutrient-sparse diet based on processed foods that are available, in contrast to the nutrient-dense diet, which is also the Paleolithic diet that humanity lived off of for millions of years. So that's just, kind of a buzz phrase that I came up with. Junk food pica, I think, is part of what we see when we see people existing off of junk foods, but they have an insatiable appetite for more junk food, right? So if what I'm saying were true, then there should also, we would like to see studies showing that a nutrient-dense diet promotes satiation. And of course, those studies have already been published. So when patients consume, and there are a couple of ways that this works. It's not simply nutrient intake, but nutrient intake is a big part of it. When people consume a more nutrient-dense diet, they have reduced appetite. And I think part of the reason is they're satisfying their biochemical needs, and their body kind of goes into a more relaxed state where it's not pursuing food all the time. The other thing is when people are on a nutrient-dense diet, by definition that means fewer calories per nutrient, which by definition we could say leans them in the direction of a low-carbohydrate diet. When patients consume a low-carb diet and they start to get into a little bit of ketogenesis, one of the fatty acids that I mentioned before, one of the ketone bodies that I mentioned before is called beta-hydroxybutyrate. So one of the benefits of being in a slightly lipolytic state or a slightly low-carb state, we could say, is the production of these ketone bodies from the breakdown of adipose tissue. Does everybody follow that? So we eat fewer carbs, we break down more fat. When we break down fat and metabolize it, we produce ketone bodies. Those ketone bodies are not just waste products. They actually have metabolic benefits. Two of their metabolic benefits are they enhance mitochondrial function and they also suppress appetite. So as people get off of carbohydrates, they feel better after they've had a day or two to adapt to that, right? First day of a low-carb diet, everybody's miserable. Second day of a low-carb diet, people are feeling better. By day 3, they're happy, right? And the reason they're happy is they have reduced appetite and their mitochondria are working better. So we're going to talk about managing some of these conditions. We're not simply going to talk about nutrition. We have to talk about how to manage these conditions. So medical management is describe it, diagnose it, physical exam, lab tests, medications, and then management. Management just means monitoring and co-management and referral. But that's the end of medical management. But in our case, we want to go beyond that. So, in other words, one of the ways I've described this before is where standard medical practice ends is where we really start. So we do the basics, diagnosis, physical exam, lab tests, but we should be able to go beyond that, and that's where the FIND-SEX protocol comes in. So these are the basic components. This is an interesting slide that perpetually gives me problems every time I have to reformat it. But basically, this is a slide of hypertension prevalence, and you can see that, but the bars that I have to insert into this slide every time I use this presentation somehow disappear. So what I want you to see is that this chart has U.S. whites and U.S. blacks. African Americans have a higher incidence of hypertension, but the incidence of hypertension in other countries is even higher. So it's not simply an American condition per se. The incidence overall is about 1 in 3 adults have hypertension. So 1 in 3 is a lot of people. It is considered to be the strongest avoidable risk factor for early death and disability. About 20% of the U.S. population as a whole, including children, or 30% of adults. These slides are acting a little strange, but we'll use them anyway. Diagnosis of hypertension, 2 to 3 readings of blood pressure over 140/90. Patient's supposed to be seated. The cuff needs to be one that fits their arm, which means not too tight, not too loose. And they need to be seated quietly for 5 minutes. You take their blood pressure, and you see what you get. If you get over 140/90, they have stage 1 hypertension. If it's above 160/100, they have stage 2 hypertension. If it's above somewhere around 220/110, then they have what we call a hypertensive urgency. If they're asymptomatic, it's urgency. If it's symptomatic, meaning they have chest pain, blurred vision, headache, altered consciousness, shortness of breath, or anuria, which means reduced urine output, then we call that a hypertensive emergency. Either way you look at it, they're going to the hospital. The books say that if they have a hypertensive urgency, they get treated with oral drugs, and if it's an emergency, they get treated with intravenous drugs. But I've seen all those patients, for the most part, get IV drugs and oral drugs. So it's kind of a weird distinction, but that's what the books say. This is a chart that comes from an article I published a couple years ago in 2006. Again, defining stage 1, stage 2, and urgent and emergency. So urgent really means elevated blood pressure without symptoms. Emergency is either severely elevated or urgently elevated with symptoms. So those are the numbers. In my own practice, the way I look at this is I'd be happy to treat stage 1 hypertension just with nutrients. So up to about 160 over 100, I am not using drugs for those patients, even though the medical profession would say that those patients all need to be on drugs. I would say they don't need to be on drugs, they just need to be effectively treated, and therefore the question becomes, what's the most effective treatment? And the answer is not drugs, it's nutrients. If a patient's got stage 2, then I either want to treat them aggressively, want to make sure they're compliant, and or I'm going to use nutrients and drugs. And emergency is emergency, and I'm not taking that